And thank you. Well, I'm going to give you a very personal view of what is the future in terms of the use of high tech and this. So we have actually several options in high tech to use for clinical care, and we have a lot of. We just heard about diagnosis, but there's many things that I would just focus on prediction, which is something which is very important in the diagnosis and clinical care. So the traditional model is you get a large cohort like this one. We put together 2 studies, nearly 24,000 patients, and you get variables which are related to this is post-discharge mortality, and then you get the multivariate analysis, and you have your predictors that you analyze then how they correlate actually with mortality. Then you create a risk score, put it all together. Then you see that actually up to 6 is something reasonable. There's very few patients actually having more than 6 of these risk factors. Then you link it to mortality, and then you get your risk score. Usually what you do is you do the sensitivity and specificity analysis. You get the receiver operator curve. You validate it with an external population. You have a second receiver operating curve, and then you have your risk score. And then you put it with the all 1,000 risk scores that is in the market and nobody uses. So why do we take so much work on that? I mean, don't be stupid. Use artificial intelligence. We just heard how it works. If you want to be cool, just call it AI, and then it looks even more better. It looks better. So let me show you an example. Then you can do this. Test this regular stacked denoise in autoencoder without efforts, which is one of the several variants of whatever is machine learning, and test it with support vector machine, random forest, blah, blah, blah. And then test all these systems, who actually very few, if any, anybody understands. And then you will see that some of them work, some of them do not work. The areas under the curve are reasonable. The accuracy may be reasonable, some in bad for others. And then you can see that actually the more you throw out there, the more risk factors that you have, actually you have better results, which it does make sense. And with that, you can actually get your predictive models. You can actually check how important these individual variables are in your model. That's important. You can actually cluster your population, and you can see different groups of patients who actually maybe have different outcomes or may need different treatments, but that is good. You can actually check whether there's different patterns of care, different patterns of behavior, different timings in events. That is good again. And you can actually check whether there's different or adverse medical events from this is from hospital. You can check it with any language. And you have, let's say, the curves or ischemic events, or vascularization, bleeding, and so on. That's good. So let's try to do it with one model. One machine learning system. So first you draw one of these machine-looking systems that engineers like. You draw one of these things. Then fill it in with impossible formulas that nobody understands. And then you check these funny things, all these systems that you have in the options with intelligent and artificial, and wow, we have it. Look, 90-something% of accuracy with QNN, which accounts actually for quantum neural network. So before you leave Barcelona, buy a couple of kilos of quantum neural network, and when you're at home, you will be wiser than Solomon. So we have it. But let's see. So we know the more that we have, actually, the prediction will be better. So let's go to UK. You have nearly 500,000 people at this biobank, the UK biobank, and actually they knew it, they have to do it. So they came up with these variables for prediction of outcomes, of cardiovascular outcomes, and what they found is actually for men and for women, there's a number of them. So let's see, then go to the different systems that we have, and then we have these AdaBoost, neural networks, funny, good, gradient boosting, and at the end, hey, what we have, 0.72 to 0.77. So we have just gained 5 points In all the non-diabetics, we do a little better with diabetics, but actually we're still in a very regular system of predictions. So after 500,000 analyses and analyzing all funny things that you can do, we do 0.77. We're missing 1 out of 4 events in these patients. So didn't we say that it was actually very intelligent, or artificially intelligent? Well, actually, one of the problems is this 0.63 is the starting point, because age actually predicts 63% of the outcomes. And then you can have that lifestyle things, smoking and so on, adds to 0.7 something, no more. So what is wrong here? Doesn't work? Well, actually, the problem is that the primary outcomes were the first fatal and non-fatal cardiovascular event, and they put together vascular dementia, coronary ischemic heart disease, heart failure, cerebrovascular, and blah, blah, blah. So how do you expect that you can predict diseases or outcomes with so different pathophysiologies? I mean, it doesn't make sense. So probably you can have a good system, but if you don't have some human neurons on it, probably it may not work. So it's not a problem of the system, it's that actually you have to put together all together. So we're working on that. I work in the National Cardiovascular Research Center. We have this study, the PESA, Bank Santander. So we have 4,000 Bank Santander young workers free of cardiovascular disease, and we followed them for 10 years with state-of-the-art, really sophisticated, non-invasive imaging, and we have 4,000 participants, more than 4,000 variables, so we have million data points. We have omics of everything, so actually we have billions of data of this. This is big data. So what we're testing, actually, we found out we're very interested in early subclinical atherosclerosis, and we see that actually atherosclerosis starts very early, both in men and women. And we were very interested in predicting which actually individuals develop atherosclerosis very early. What are these predictors? And so we used machine learning to do that, and you see up there that age actually is the strongest with any model, which are the vertical lines that you have. In blue, those who are negatively related, and blue and reddish, those who are positively related. And you can see that putting together, actually, you can, the traditional risk scores, you can improve something. And 0.89, that's one with elastic neck, which is, I guess, one of these systems. And you have a nice accuracy, and you can actually have a sense. So this is already ongoing. We will see how effective we can be in predicting subclinical atherosclerosis. But that's not what we want. We want to predict events. And actually, I'm going to be finishing with this. The MESA is a very similar study of subclinical atherosclerosis, but they have events. So they put together this cohort of the MESA cohort in the US and the Flamingo from a Flemish cohort. They put together and they use machine learning to compare with the ACC-AHA cardiovascular risk calculator. So they have a lot of events, different events, so that's good, so you can have a clinical. And actually, the ACC-AHA actually get a reasonable predictive model, 0.86 for heart endpoints, 0.84, or 0.63 in female, and 0.62, so worse in female, and you go with the machine learning, actually you get an improvement. So particularly for all cardiovascular disease events in women. So actually you can make it better. And so the blue lines are nearly a triangle, which would be the ideal predictive model. So we actually get it there. And the most interesting thing is actually that you can operate that. And this is an example of using the one or other system. What would be the proportion of individuals who would need a statin to predict an event? And you will see that with the ACC-AHA, actually 46% of patients would need a statin to prevent a heart endpoint, while only 11% could be done with this system. Or even more patients to predict any cardiovascular event. But also you can see the other way around. There's a number of low-risk patients who actually develop events. We know that. And actually this is what is called missed opportunities. And these can be prevented with the ACS chain model. But actually it is more precise using this machine learning system. And I think this is the future. I think we need to go this way to really integrate these systems to transfer it to really clinical decisions. But to me, the challenge is, and these are my conclusions, that still while we work separately between those who develop artificial intelligence or this technology and the physician, this is not going to work. We need to integrate that in our clinical practice. We have to have multidisciplinary discussions. We have to work together. And for that, we need to change a little bit. We're still working in hospitals, in silos. So we need to really work together. And second, I think there's still, I don't know if you realize many of the references which kind of journals have. So we have a lot of marketing, things that can be done, but we really need evidence that this is efficient, this is safe, and this is helpful. That is the kind of need. I think that's the future. So we need to be scientists, even although this looks really fancy, and probably it's very useful, but we need to check it. We need to integrate it. We don't want a repetition of health clinical records that actually becomes a burden, takes our time, takes our complexity. It needs to be integrated in the system and works in the back without increasing the complexity. We need to say how we pay that. So thank you for your attention.